All right, we've reached the half-hour mark, so let's get started. Welcome, everyone, to this week's installment of AMSSM's National Fellows Online Lecture Series. My name is Matt Wise. I'm an assistant professor in family medicine and orthopedics at UT Southwestern. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on traumatic injuries of the hip and knee, which will be given by Dr. Christopher Kwan 1 week from today at the same time. For tonight, I am very excited to welcome Dr. Christopher Bailey to speak to us on mental health and sport-related concussion. Dr. Bailey is a neuropsychologist at University Hospitals Cleveland Medical Center and is a professor of neurology at the Case Western Reserve University School of Medicine. He also serves as the director of the neuropsychology section of the Neurological Institute, director of the UH Concussion Management Program, and director of the Adult Neuropsychology Postdoctoral Fellowship Program. At University Hospitals in Cleveland, Dr. Bailey has worked collaboratively with multiple departments and specialties to update, integrate, and standardize concussion management services across the hospital system, including developing a multidisciplinary concussion specialist network to improve concussion identification and management on and off the sports field. His current clinical roles include being the neuropsychological consultant to the Cleveland Browns, Cleveland Monsters, and assisting in the management of sports concussion at multiple colleges, universities, high schools, and youth sports across Northeast Ohio. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts, and ultimately to assist in CAQ exam preparation. Some reminders to please mute your device's microphone and turn off your video. Submit questions through the chat function. I, as your moderator, will ask the questions during the Q&A at the end, and then please complete the evaluation at the end of each lecture. Two more discussion points. One of our new efforts is to facilitate more input from our audience. There are a couple ways we can do this. First, a web link can be found by going to amssm.org, click the Education tab, and then select Fellow Online Lecture Series. The link is near the top of the page as seen in the screenshot at the top right. And that'll take you to the screenshot in the bottom right of the screen to fill out the form. Second is by scanning this QR code. So it should take you directly to the form that we just saw in the bottom right hand of the screen. When filling out the form, we ask that you please keep in mind that the primary goal of this lecture series is to assist in CAQ preparation for our sports fellows. And lastly, a quick plug for AMSSM's Library of Sports Ultrasound Pathology. Please consider contributing by scanning the QR code on the screen. Now, without further ado, please welcome Dr. Bailey.
Well, thank you for that. Just one update actually to that bio is that I am now the past president, actually, as of 2 weeks ago of the Sports Neuropsychology Society. I'll talk a little bit about SNS as a part of this talk. I mean, it's a part of my disclosures. Nothing that's really significant. And actually, most of this was actually talking. Actually, most of the reasons of my disclosures are why it is that I have some sports concussion sort of expertise is that I work with basically some athletes. So the outline for today is, I'm going to talk some about mental health and concussion. We're going to talk to begin with about athletes and psychological symptoms and mental health pre-injury. Then we'll talk about the risk of developing some of those symptoms after injury and how that affects recovery to some degree. We're going to talk about some concepts like fear avoidance and resilience, which may underlie the development of psychological and mental health symptoms post-injury like that. And then we'll talk a little bit about how how we might manage it, recommendations about what to do when people have these kinds of problems. And I got a couple case examples. We'll see if we get to those or not. I'll hope to try to get to those. I thought I would just spend a second talking about sports neuropsychology. So people in sports medicine these days do have a sense of neuropsychology. It's still worth mentioning kind of what a neuropsychologist is. It's really a specialty that focuses on brain behavior relationships. So people that become a neuropsychologist, they get a clinical psychology doctoral degree. That's either a PsyD or a PhD. And then do a year of internship and then 2 years of fellowship in essentially behavioral neurology. So kind of working with a variety of different cognitive, central nervous system sorts of problems, and then identify what the behavioral and cognitive changes associated with those conditions are. And on fellowship, we have a whole host of competencies that we work through. But I like to remind people that we don't just do head injury. So head injury is maybe 50% of what my practice is. But there's a large proportion of my practice that has nothing at all to do with sports, and is actually in the DBS world, so deep brain stimulation. I work with pre-surgical deep brain stimulation and epilepsy patients to identify dementias and memory conditions in people and identify people that are appropriate or not appropriate for different kinds of surgeries. We also identify dementias and memory conditions essentially across the spectrum of neurological disease. And I would say that those problems are just as informative in my concussion and sports concussion practice, as well as the relationships that I develop in that, essentially. So again, I'm working with neurology and neurosurgery and psychiatry and all of these other ways, and that then helps to inform my sports concussion practice and focus as well. So thinking about neuropsychology broadly, I think is important. And then on top of that, then we actually then have the sports neuropsychology focus. And so, like I said, I am just the recent past president as of May 16th, I think. So just recently. Um, and what a sports neuropsychologist is essentially and we defined this back in 2023, is to basically kind of follow those same competencies, but then to work with athletes of all levels and ages, and backgrounds. And a lot of that actually has to do with concussion management. Specifically, oh, there you go. Specifically with a kind of multidisciplinary team is interdisciplinary teams are very common, where neuropsychologists are working with athletes, both in sports concussion as well as just kind of general brain health, with a real focus on client safety as a part of that. I know that I always like to mention when it is that people might think about referring to see somebody in the sports neuropsychology world. We do exist, and we exist everywhere. So I know Dr. Wise, you mentioned your UT Southwestern Monroe Cullum is a past president. I don't know if you know Monroe down there. So
Yeah, I've heard his name spoken at all the high levels of sport. Cowboys, TCU, you name it.
yeah, so there's several. I mean, UT Southwestern is one of the hubs of sports neuropsychology for sure. But we're all over the place, and again, I think it's really relevant. I think for sports med docs to try to identify somebody that's in their region to be able to send people on to. And when we normally do that, I mean, so sometimes it's a requirement of the protocol. So I'm required to see every pro NFL player that comes through our team when they're injured as a part of the protocol. The same is true for NHL, AHL, and MLS. So they're required to have a face-to-face neuropsych as a part of the protocols. Sometimes people are just coming to me because they're having a prolonged recovery, and we're not sure why that is. So often our sports docs here at UH and CASE are sending people on when they're sending them to PT and they're sending to neuropsych about the same time a lot of the time, to try to better understand what's going on when somebody isn't recovering the way we'd expect. If they're struggling in their computerized testing through the schools, if they have a complex psych history, like we're going to talk about here, that's another common sort of referral, a history of a lot of depression or anxiety that may be interfering with recovery. A lot of times there's, especially in a large system like ours, we cover about 30,000 athletes in Northeast Ohio here. So it's a very large system that's here. And so with that, we see a lot of things, including a good number of structural brain injuries that actually do occur. A lot of times those are going through neurosurgery first. And then after neurosurgery, they come to neuropsychology to see where they're at in the recovery process. And then when they're ready from that, then it goes on to sports medicine to work them back into sport. So there's a few ways essentially that it works around that. If they're having trouble in school, I would also say anytime somebody's thinking about retirement, that's a multidisciplinary sort of question to be thinking about. Really, how is this person recovered? What's their background look like? What's their risk in the future? You want to have a few different hands in that pot, and I think neuropsychology is a really important one that makes a lot of sense there. So let's talk about athletes and psychological distress. Like I said, this is definitely one of the areas that our sports docs are regularly sending people on to us for when we're seeing some of this. And I think it's relevant to mention that it's common for athletes to have some distress. So one of my early publications that I had was at UVA when I was on fellowship. This is back in 2010. It was published. We collected it in 2009. But we looked at 47 D1 college football players. They were doing baseline concussion testing, and we actually did a full personality inventory, the personality assessment inventory, which is like an hour-long personality test. So yeah, you can imagine how hard it is to pull teeth to get athletes to do baseline testing anyway, let alone adding in an hour-long personality measure. But we did that, and and interestingly, what we found is that these are all elevations, and as a note, the T scores over here. So a T of 70 is actually 2 standard deviations above the normative mean. A T of 65 is 1.5 standard deviations above the mean. So those are pretty clinically relevant. Those are pretty meaningful elevations. And then across that sample, about 1 in 3 of the college football players had meaningful 2 standard deviation above the mean elevations in some category of psychiatric issue. And if you move it down to the borderline level, that T of 65, it's actually 1 in 2 people. So it's actually fairly common. There's another systematic review of about 3,000 athletes that was done. These are elite athletes, so that's defined as professional or Olympic athletes, that was done in 2018. And this showed about 1/3 of those athletes had clinically relevant mental health diagnoses and mental health symptoms at that time. And the vast majority of multisport samples in high school and college really have about 15 to 20% of their athletes have some sort of meaningful degree of mental health and psychological symptoms, at their baseline to begin with. Now, it's worth mentioning that this is actually data from NIMH, so the National Institute of Mental Health, just looking at the general prevalence of mental health illness in the U.S., and it's about 36% in that age range that we're talking about here. And if you actually look at the lifetime prevalence in high school, it's somewhere about 1 in 2. So though athletes are likely to have mental health problems, they actually have them a little bit less than what is typical in the normative samples of the US population. And so, so sport participation in some ways is a little bit protective. So though ultimately athletes have symptoms, it's a little bit less probably than the average adult or high school person in the US. Um, how does psychiatric history relate to sports concussion? So, there's actually been a couple systematic reviews. So prior to the consensus statements that are done in sport concussion, which my guess is the audience is pretty familiar with, there's always systematic reviews of the data that exist to decide, what is the information that we need to include in the sports concussion consensus statement. In 2017, Grant Iverson ran the systematic review that was used looking at predictors of recovery following concussion. And what he found was that the psychiatric history was a pretty relevant factor in that recovery process back in 2017. So that informed the Berlin statement, the consensus statement. But though that was pretty present and meaningful, you can see there's not tons of studies that were done at that time. And then Margot Patukian updated that here for the most recent consensus statement in Amsterdam. And that study was published in 2023. And what she found was actually pretty different, was that these are looking at relevant studies. So the blue bars are the numbers of studies that met the criteria, and actually things like ADHD, LD, psychiatric conditions, anxiety, depression. There was actually more studies that showed no difference than a significant difference in terms of their recovery process. So again, in terms of their ability to predict whether or not there was kind of a delayed recovery. So I think the ultimate sort of takeaway from that information is that I think the history of psychiatric conditions are relevant, It's just you can't assume that if a person has a history of depression or anxiety or some of the psychiatric condition, that it is absolutely going to lead to a prolonged recovery. And in fact, there's probably some nuance to that. And I think that one of those nuances may actually be related to somatization. So what somatization is actually a tendency to experience physical symptoms during periods of distress. So essentially, this is when an athlete may experience significant depression or anxiety, and when they have that, they get headache, they get nausea, they get some IBS symptoms. It's essentially again where they're getting physical symptoms in relationship to the distress that they're experiencing. Well, the Medical College of Wisconsin group in 2016 was able to take a look at about 2,000 high school and college athletes. And what they did is then from that 2,000 athletes, they had about 127 concussions and they followed that longitudinally. They did a baseline evaluation and then they looked at it at those concussions at 24 hours post-injury, 8-day post-injuries, 15 days, and 45 days. And they looked at what would predict symptom resolution. And there were two things that they found from their baseline and post-injury evaluations that eventually predicted the resolution. And one was the athlete's tendency to somaticize at baseline. So if they were a low somaticizer or a high somaticizer, the low somaticizers took far less time to recover than what the high ones did. And then the other thing was their acute concussion symptoms. So the acute symptoms following injury, and there was a meaningful mediation process that happened with that, meaning that the people that had a tendency to somaticize had higher concussion symptoms, and that led to longer recovery process. So there was this sort of pattern of the fact that so again, it kind of explains this idea that psychological distress at baseline may or may not be related to outcome. And in fact, what might mediate that is if that psychological distress is associated with physical symptoms, which are the things then that are going to be more likely to be present post-injury. And then that may be more likely for people to have longer recovery times. So let's talk now. So we know that athletes can have some meaningful distress at baseline. Again, a little less than normal populations, but still they have it's possible that they have those symptoms. And if they have a tendency to somaticize, then it may prolong their recovery some. What about the experience of psychological distress and mental health symptoms after concussion? So not necessarily pre-injury, but now let's look at the development of that post-injury. Well, we know that in concussion patients outside of the sports context, that this is actually very common. Really for all forms of TBI, whether it's mild, moderate, or severe. This is actually a study from Mass General that followed adult patients between 2000 and 2015 who had at least one visit and were 6 months to 10 years post, and who actually their risk of development of a variety of different disorders. And this is relative, the hazard ratios, so relative to controls. And people are 5 to 10 times more likely, depending on the problem that we're talking about, for developing these different kinds of conditions. And then another study looking at the non-sports populations shows that even 10 years post injury, or excuse me, 5 years post injury, these patients are still, there's still a significant number of people with concussions 5 years post in the non-sports world that are that are developing these new problems following injury. Well, what about athletes? Do we see this same sort of process? There's a cross-sectional study from 2015 that looked at D1 college athletes. This is a sample of 71 concussions. And what they found is that in the acute phase, about 20% of these college athletes had depression, and about a third had anxiety. Now, this was, and there were some differences based off of things like sex and sport and race. But because this is cross-sectional, we don't really know if that is development of new symptoms or if it's just present. And if you remember the data that I said before, I mean, 20 to 30% is somewhere where you sometimes can see that in athletes. This is actually a study looking at high school athletes. That is a longitudinal study that follows that was actually able to follow athletes over time from baseline to post injury. You have 125 concussions. That what you see is that post injury. So at baseline, so at least some degree of depression on the PHQ-9 was present in about 13% of athletes. And then within the acute phase, so 24 hours to 7 days post injury, it actually gets up to about 24% of that sample now developing. So there's definitely an increase in the number of people that begin endorsing some of those kinds of symptoms. Um, However, what's different about the athletes versus the non-athlete populations is that you can see that it's fairly short-lived, that increase in depressive symptoms in this longitudinal sample, it really resolves for the most part by the time that they return to sport. So instead of this being something that is present for months or even years afterwards, like you see in some of the non-sports groups, the sports groups tend to have it present early and then it resolves relatively quickly in the majority of the athletes, which again is a little bit of a different process. Now, one of the problems that we run into, in the concussion world, when we're talking about mental health, but when we're talking really about most things, is that symptom specificity is a real issue. So, concussion symptoms are notoriously non-specific. So headache, dizziness, nausea, trouble with sleep, trouble with mood, trouble with stress, trouble with my thinking, trouble with my vision. These things happen with so many other kinds of problems, whether or not we're talking about cervical injury or migraine or sleep disorder or there, a variety of other musculoskeletal issues. There's lots of problems that produce these symptoms, right? And certainly psychological symptoms are very common to also produce many of the symptoms. So I listed out some of the symptoms there on the SCAT symptom scale to the left there that are actually core criteria of a variety of different mood or anxiety disorders that exist. It makes it really difficult to know whether or not the symptoms that an athlete might be experiencing, following injury are really acutely related to the biology of the concussion, or is it something that's more associated with kind of the coping and a maladaptive response to being pulled from play or from being worried about school or worried about keeping their spot on the team and a variety of other things. My experience of that clinically over the years is that the biologically driven affective symptoms tend to be very acute. They tend to be very early on in the sort of post-concussive sort of space, and they tend to be fairly incongruent with environment. So this is where like the athlete is crying on the sidelines, after injury, which is very unusual, not something that is typical, and is very acute after the injury. Whereas if they develop some of those kinds of symptoms days post, if there's a delay and there really isn't the incongruence, essentially they have a stressor and they experience a higher degree of distress associated with that. That's something that tends to be more on the coping side than it is on the biology side. So let's talk some about, again, more about the acute psychological symptoms in recovery. So, what do we know about how those new and acute development of symptoms, they might impact injury recovery following concussion? This is actually a 2023 study from Vanderbilt. It's really a retrospective review of about 400 high school athletes that were all seen at a regional sports concussion center within about a week of their injury, and then followed by the providers over time. And then they went through and then did a retrospective review of when it was that those athletes returned to school, so returned to learn, they had symptom resolution, and when they returned to play. And they developed a psychological cluster of symptoms from the PCS scores. So they basically used the symptoms that were already present on the concussion scales and created their own sort of cluster, essentially, their own, excuse me, measure that could be used for predicting things like return to learn and symptom resolution. So this is actually showing the prevalence and of the endorsements that you see. Is again, the vast majority of these athletes 70-ish% of people are not endorsing any of those symptoms in that sort of in that post-acute kind of phase when they came into treatment. But then there's a good number of people that endorse at least a 1 on some of these affective symptoms. And if you actually look at it, in that symptom cluster score that they developed, it's really about 45% of their athletes in this sample endorsed at least some degree of symptoms in that cluster. Now, what does that symptom cluster tell us? So if you are endorsing some of the symptoms in this versus those that are not, how predictive is that of things like return to learn? So they entered a whole host of things into, I know this is a very busy slide, but there's a whole host of things that they entered into this regression. And over here on the right, what you can see is that there's only a couple of them that were significant, that survived that. And that psych symptom cluster score is one of them. That amnesia and the history of ADHD were the only things that were predictive of return to learn. Symptom resolution, the only thing that actually that held out in that was this psych symptom cluster score. And then return to play, it still was also among the things. And in each one of those cases, higher degrees of endorsement in the psych cluster was actually more associated with longer return to school, longer symptom duration, and longer periods before return to play. So we know now that athletes may experience worsening of psychological symptoms after injury, though it's transient. And if elevated, it can be associated with prolonged recovery. But I think it's important to also think about what might be driving some of these kinds of symptoms. So what are some of the things that could be driving this? We're going to talk about 2 concepts that are relatively new, and there is some new data that's behind it supporting it. One that's what we call fear avoidance, and another that's resilience, and they're sort of opposites of each other in some ways. So fear avoidance actually comes from the chronic pain models that was actually used to develop. It's basically where there's kind of 2 primary coping reactions to fear of pain. One is that you confront it, and another is that you avoid it. And what you find is that individuals with a heightened fear of pain response and avoidance tendencies, they tend to have longer developed, chronic pain over time. It's kind of a peak and pass sort of model where instead of essentially going in and confronting it and then experiencing it and then getting past that, it's something where you avoid it and then it kind of develops more power. So this is called fear avoidance. There's also some groups that call this kinesiophobia as another term for it. There's a tool that does exist out there, the Athlete Fear Avoidance Questionnaire, that actually is a way to kind of quantify this. And actually, it asks athletes, whether they agree with the different statements here on a scale of 1 to 5, 5 being completely agree and 1 being not at all. I will never be able to play as I did before my injury. I'm worried about my role with the team changing. I'm worried about what other people will think of me if I don't perform at the same level. So again, this sense of worry that is combined with pain as well. And what we find is that these are highly related both to psychological distress, the development of psychological distress, and then also the experience of symptoms post-concussion. So this is a 2024 study that was out of Quebec. That looked at 60 college athletes. It's a multi-sport sample. It's Canada, so it's high hockey content. So 68% male. They all were administered that athlete fear avoidance questionnaire. It was highly correlated with depression and anxiety, so correlated at 0.48. So pretty meaningfully correlated with both depression and anxiety. And then it also predicted things like concussion symptoms within 48 hours of injury. And so what you look at here is you can see that pretty clear relationship between the fear avoidance and also the number of reported symptoms. And then when they developed regression models to predict concussion symptoms, what you see is that both concussion symptom severity and concussion symptom frequency, about 50% of the variance, 40 to 50% of the variance was accounted for by depression, anxiety, and fear avoidance. And at times, again, because of these are so highly correlated concepts. The depression and anxiety was the only thing that was really kept in the models, because fear avoidance was essentially, driving some of it. It was kind of mediated by it. Jake Resch and UVA did a follow-up study looking at, again, that kinesiophobia concept, the same, very similar fear avoidance concept, to not only look at whether or not this is related to the symptoms acutely, but also to look at how does fear avoidance relate to symptom duration. And so what we're seeing here are the violin plots of when it is that people have the days to recovery, and you have the low kinesiophobia groups, the low fear avoidance group, and then the high fear avoidance group. And the high fear avoidance group was about 5 days, or excuse me, was about 2.5 days more in terms of the symptom duration than the ones that did not have that. And again, it was highly correlated to the development of depression and anxiety. Like I said, some authors have looked at this in a different way too. So they've looked at the idea of resilience, as opposed to the fear avoidance. So really, this is kind of like an opposite concept. It's a capacity to adapt positively to adversity and stressors. And in athletics, it's also things like your ability to recover from setbacks, to maintain motivation, to perform optimally under pressure. And there's a brief resilience scale that was developed, several years ago. That it's among the kinds of things that people use to take a look at this. So this is actually a scale that you rate how much you agree or disagree with the different statements. I tend to bounce back quickly after hard times. I have a hard time making it through stressful events, and so forth. So kind of again looking at your ability to be resilient after different sorts of problems. And speaking of UT Southwestern, so this is actually data from UT Southwestern, um, um, looking at 332 participants. They were high school and college athletes, about half females, multi-sport. They were all diagnosed with sports concussion and enrolled within 10 days of that. Um, and then followed over time. And at the 3 month follow-up, so you can see there's a lot. These are small graphs, but what you see is that the red lines are the ones with low resilience at their first appointment, and you can see that they significantly break away from all of the other groups, the average and high resilience, in terms of the number of symptoms that they endorse, the severity of symptoms, their anxiety, and their depression. And in fact, at the 3 month follow-up, people with low resilience were much more likely to have exacerbation with physical activity, exacerbation with cognitive activity, and to be symptomatic at that 3 month time point than the ones that were either average or high in their resilience. And just a year later, after that study was done, UPMC did another pretty well-controlled study looking at high and low resilience, again in a multi-sport sample, but relatively well-controlled across those different sports. So it's a smaller group here with really only 45 athletes. But again, with that well-controlled study, what you see is that really all aspects of concussion evaluation, whether or not we're talking about days to recovery or their symptoms or their depression or anxiety, their vestibular performance on the VOMs. Many of these factors are very significantly different between that low and high resilience group. So again, these are all things that can potentially underlie the psychological distress that develops after injury. So these kinds of concepts of resilience and fear avoidance, possibly related to the development of distress. So who are those athletes that are developing depression, anxiety? And again, I think that's information that we can potentially use for understanding how to approach management of those athletes as well. So, what can we do about it when people have these kinds of problems? Now, it started out by saying that, I don't think that there really is a gold standard for what it is that we would say you should do. I can tell you that most of what I'm going to talk about here are the things that I feel like are important to do, that I've kind of developed in my own practice over the last couple decades. Um, and the first thing is that it's important to assess for it. So to understand, whether or not psychological and mental health problems are among the things that are going on with an athlete. And you can do that through standalone measures like the PHQ-9 or the GAD-7 or the BDI fast screen, or there's a whole host of different sorts of relatively brief measures that you can do to evaluate whether or not your athletes have these kinds of problems. But you can also just use the standard concussion scales like the psychological symptom cluster. And I would say that honestly, just using elevation alone is one of those things that tells me that I'm starting to be a little concerned. That something like if I see an athlete that has a symptom scale that's over 50, really at any time in their recovery process, I'm starting to wonder whether or not a meaningful degree of psychological stress is present. And I would say that it's really critical that we identify those athletes whose confidence is shaken in that early phase, because we want to try to get those people into something like sports psychology or some sort of treatment early on, because really in my experience, an athlete's never really ready to return back to sport, even if I feel like their concussion has resolved, if they're not feeling confident about getting back in there. So again, we really want to identify those injuries. That's really important, or the affective symptoms. Education is key. Education is treatment. It's really important for when athletes come in that they understand more about. So this is what's going to happen. You're going to have some symptoms. It's going to be bad to begin with, but everybody gets better. This is not something where we're really concerned about whether or not you're going to get better. It's really more about the when are you going to get better. So it's not a question of whether, it's a question of when. And in just helping to inform those people, we know that then actually then reduces the duration of symptoms post. And that's probably because it's instilling some of those things like resilience early on. So as then you're normalizing their experience and you're helping them to kind of develop more adaptive coping skills with that. So again, education is really important. I also say it's really important for us to get our athletes active as soon as we can. It's obviously if they're very symptomatic and they're not tolerating activity, then you don't want to push that too much. At the same time, keep in mind, the most recent systematic reviews from Amsterdam told us, that 90% of athletes are back to school within 10 days after injury. Anytime I see an athlete, post injury and they're 2 months out and they're not in school, it's a concern. We know that there's going to be lots of problems. And honestly, it dramatically affects their distress. They're super anxious because they have all this schoolwork that they have to try to figure out what to do with now that is built up over these 2 months. So again, we want to get people back to school. We want to get people back to exercise. Even within the first couple days post-injury, some light degree of exercise has been shown to be a safe thing and can reduce that prolonged process. And it's not just that it can reduce the prolonged process. There's actually some evidence that exercise can treat those people that have the high degree of mood and psychological symptoms post. So this is actually data from the University of Buffalo and the Children's Hospital of Pennsylvania, so CHOP. That is actually a true randomized clinical trial of exercise in individuals who have high psych symptom burden after concussion. And what they showed here is that if you are low psych symptom burden, the recovery curves were about the same. It doesn't really matter. And again, you may not be able to see this, but the low are the non-dotted lines. But they're basically about the same. So the low psych symptom burden, you see the same sort of recovery curves. The high psych symptom burden, if they have exercise, it looks the same as the low. But if they were stretching instead of exercise, then that breaks away and those athletes take longer. So it actually negates the psych symptoms to get people active, to get those athletes active. So again, exercise is a treatment both for the psych symptoms. And honestly, I would say that it's hard for us to even say in some ways that this effect isn't the only effect of our subthreshold exercise protocols in many ways. That actually what we're doing is moving people from something like a passive coping strategy following concussion to an active coping strategy when they are getting in and exercising and doing the kind of LEDI protocols like that. So get them active. It's an important thing. I would also say, have treatment options. So again, sometimes people have meaningful clinical psychological distress, following injury. So again, they can have significant distress. They need to see clinical psychology. They need to see maybe a psychiatry at university hospitals here. We actually do have a sports psychiatrist group. So they actually do medication management with athletes that are coming through with different kinds of problems. And a good sports psychologist is really important. Again, those concepts of things like resilience and fear avoidance are really a really common thing in that sports psychology world. So it's important to have, places you can send these people to. And I would also say that, I think there are some important treatment things that are going to be present here in the future. I see a real important role for biomarkers in this space, actually. So knowing again what is injury versus what may not be something that is related to injury and is more related to coping is something that in that post-acute phase, things like biomarkers may be able to tell us in the future. So again, if their GFAP actually starts to level off and become normal over time, but they're still highly symptomatic, that might suggest that maybe this isn't the injury anymore. Who knows? But again, I think that it's very likely that these kinds of things in the future are going to be helpful. I think we're also going to start to develop some really targeted behavioral interventions. There are some things that do exist out there. But again, I think that when we see things like resilience and fear avoidance being really related both to psychological distress and concussion symptoms, I think it's very possible that we can institute some treatments that will help to move people from the low resilience to the high resilience, move people from the fear avoidant to the low fear avoidant sort of groups. And that may then also lead to better symptom resolution and better outcomes following concussion. So those are the main things that I'm going to talk about. I've got just some final thoughts here in conclusion. So, I mean, athletes, they can have sort of pre-existing psychological, mental health symptoms. And if they have a tendency for somatization, we know that sometimes that can be related to recovery. Athletes can be at risk for development of psychological and mental health symptoms after sports concussion, which may delay recovery. And that may be related to some degree with high fear avoidance and low resilience, that those athletes are at particular risk for the development of those symptoms and worse outcome. But this is manageable. We manage it by assessing it, by educating, by getting people active, and then treating it when you need to. So there's a couple things we can do. So I want to just throw again a quick shout out to sports neuropsychology. So next year, our next meeting is in Nashville. If you like this kind of content, then try to get to the sports neuropsych meeting. It's again, I'm biased, but it's a very good one. And again, we talk a lot about athlete brain health and these kinds of things. So I mean, I want to we've got about 15 minutes left. I've got a case or two that we could talk about. Or if you want to spend some time answering some questions now too, we can do that. I'm not sure what people want to do. We can kind of leave it up to our audience, or I can just keep going. What do people want to do?
I think in general we love using doing case examples. So
Sure.
and taking the time to prep it. So let's dive in.
Let's do it. Great. Well, if you have any questions, just shout them out. We'll kind of go that route. So the first one I'm going to talk about is as a pro athlete. So he's a 29-year-old right-handed professional football player. Had an injury about a week ago prior to my evaluation. There was a helmet to turf contact when receiving a pass. Did not have loss of consciousness. Had no amnesia. Immediate headache and blurred vision. Was immediately removed by the sports med staff. Had a decline in performance and elevated symptoms on the SCAT when they did that in the locker room. Since that time, progressive improvement. So symptom free at rest for the most part, reporting some kind of residual neck sort of weirdness, but otherwise saying for the most part that he's doing okay. Not reporting any symptom exacerbation. At the time of my appointment, he said that I'm getting a little dizzy sometimes when I stand, but I think it may be just a little respiratory thing. I don't think it's anything that's especially related to this injury. And didn't think it was particularly concerning. Now, this athlete's had 4 prior concussions in the last 6 years. 2 concussions 6 years ago, 1 2 years ago, 1 last year. So he's had several concussions. They were all cleared through the concussion protocol. That included hybrid testing. So that included computerized and paper and pencil testing. 3 out of the 4 cleared within 7 to 10 days, which is the average in the league. The most recent one about a year ago took about a month. And he had a meaningful degree of anxiety during that time. Really starting to worry about whether or not he's at a place that needs to retire. Is really what's coming up for him. Um, he also has some migraine history that actually does have visual aura with it. So childhood onset, migraine back then. Hasn't had a whole lot of that recently, but it's relevant. Um, he has a whole lot of testing available. So we've done a bunch of tests with him, both 3 prior hybrid baseline tests that includes computerized and paper and pencil pre-injury tests, and he's got all of the post-injury testing that we've done with him too. So we have a whole lot of data to be able to make comparisons with this person. And the team involved here was sports medicine, the athletic trainer, the PT through the club, myself, and then he also met with an outside expert too as a part of this process. So this is actually taking a look at the data that we collected. So the descriptors, so this is the unified descriptor system that we use in neuropsychology. Exceptionally low is basically second percentile, exceptionally high is 98th percentile, and there's different descriptors kind of fall within the ranges between it. These are all the different sorts of cognitive domains that we took a look at. So again, you have the paper and pencil testing over here on the left, and then you have all of the computerized testing over here on the right. And then we have baseline testing. So these bars here are the black ones are the most recent baseline on these. The red ones are an aggregate, so an average of all of the baselines that were done. So like I said, he had some mild symptoms. I just don't feel quite right at times was basically what he said. And if you look across the testing, I mean, there's a few of these measures that weren't quite back to baseline at this point. So it was a decline in verbal memory. Yeah, it was a decline in verbal memory, a decline in the computerized testing, both in verbal and visual memory. And he said, I think I really might have to be done at this point. And it was what he's doing. He said because of that I'm gonna meet with an outside person. He actually went to see a separate neuropsychologist in a different system, just to get another perspective on it. And I always encourage that if somebody's thinking about something like retirement, that it's a time to get it, a few different perspectives on that. He went and did that. With that, he actually was told that, hey, I think things are going to recover fine. I don't think you have any sort of thing to be concerned about. And really, with that education from an outside person that was somebody that the athlete saw as being totally, uninvested in, in the club, and it's something that they felt like they could feel, confident about. He felt a whole lot better. It was, really felt like that I'm getting to a place now where I can go ahead and get back into sport. And so then we repeated it 10 days. It was only 3 days after that. And what you see here is that everything's back to normal. And he no longer endorsed any symptoms. And it does really make you wonder. I mean, so there's a little bit of a change. You can see over here that there's the little bit of a dip in this one, this reaction time relative to the other test. But you can see that the aggregate is actually about the same. And he's got a lot of variability on that reaction time. Really, I read this as a completely normal performance at this point. And I really wonder whether or not, that the reason he was still a little symptomatic at that post-injury, that first time point, and a couple of those scores were a little low, was really less to do with injury and more to do with the concerns about retirement and the distress associated with that. And I think that was, a particularly kind of important and relevant, concept of what was going on at that. So I've got another case if people want to talk about that, or if there's any kinds of questions. This next one's a little more complex. There's a few more things that are going on in it, and we can talk about how there's a kind of a complex interplay of a few things here. This is actually a 19-year-old junior A hockey player. So for people that are or not familiar, so it's the Canadian Junior Hockey League. So there's 9 junior A hockey leagues in Canada. It's 118 teams, about 2,500 players. These are 16 to 21-year-old. It's essentially, the step right below professional hockey. It's super competitive. A lot of the people that go and play in these leagues, they actually leave high school in the middle of school and try to get a GED and then go out and do this. It's really a kind of a step under the NHL in many ways. So this is a junior hockey player in British Columbia. Um, Had a sports concussion that he sustained about 10 days prior to my appointment. Had no loss of consciousness. Was identified by being slow to get up off the ice. Was immediately pulled by his sports staff. Had some mild symptoms on the SCAT and performed below baseline on the cognitive tests for the SCAT. Was placed in the protocol. Um, was in those initial steps of rest and restriction relatively early on. Did not have an ED visit. Didn't have any imaging or other kinds of neurological workup, which was the kind of the normal way of the protocol, as it is for most groups. Um, some other kind of relevant background, though. In this athlete, he had 5 prior sports concussions. Also, he's had 2 observed generalized tonic-clonic seizures. One that was about a year ago that happened about 3 weeks after his sports concussion about a year ago. And then one that was in the context of this injury. So about 2 days after this concussion, he had a seizure that was observed by his teammates. He was actually hanging out with the club. They were playing video games, and he had a seizure. And they rushed him to the hospital. Had imaging done at that time that was read as normal. He did show a generalized spike in wave discharge. It doesn't have a whole lot of meaning on EEG at that time. But he has these 2 seizures that have occurred kind of in the context of injury. ADHD was diagnosed, when he was in high school. He does have stimulant meds, but he's not on them. He also has depression, but again, this depression has developed here recently because he's worried about what the seizures mean and about his concussions and what all of it means and whether or not, he's basically devoted his whole life to hockey. I mean, he in fact left high school to go become to go be a hockey player in Canada and got a GED there, and he's really kind of put all of his eggs in this one basket. And so pretty depressed about possibly having to retire if that's among the things that he's worried about at this point. So the team that was involved here, so our neurologist, sports medicine, PT, we got sports psychology involved here as well, and then myself. So, on testing, so we didn't do computerized testing with this because we didn't have access to the computerized testing that was done for the club. So we just did our paper and pencil testing, but he actually did have psychoeducational testing to diagnose his ADHD. So we were able to kind of use both a pre-morbid estimate. So in neuropsychology, we have certain tests that kind of hold steady, certain ones that don't change even with injury. And so you can actually give those tests to give us an idea of what their likely baseline is. And so his pre-morbid estimate put him at the average range. And then we also have his prior psychoeducational testing that showed us where working memory and processing speed should be. So we have some previous testing, and what you can see is that he's not quite there. At least in the working memory and processing speed, he's got some meaningful declines relative to where both this pre-morbid estimate as well as that previous psychoeducational testing. And executive functioning is also down, but we don't have any kind of previous testing to tell us where executive functioning should be, and that's certainly a common ADHD symptom as well. Now, on screening measures for things like depression and anxiety, we did do a BDI, so a Beck Depression Inventory, and he had moderate clinical level depression at the time of this evaluation. He had no recent seizure activity. So like I said, he had the one that was 2 days post. We were seeing him 10 days post. In the last week, he's had no new seizures since that time. So what do we know about post-traumatic epilepsy? So I actually do a whole course on this for our neurology residents to talk about things like concussions and epilepsy. So seizures certainly can happen at the time of trauma, and it's important to distinguish what is post-traumatic epilepsy from seizures that occur in the immediate phase. And in fact, because they can happen at the time of trauma, they're actually a part of our no-go signs. So having a contact seizure or fencing postures are things that we use to identify that injuries occurred and are ways for pulling athletes in a lot of things. So to define this, immediate seizures are things that happen within the first 24 hours. Early seizures are ones that happen within the first week, and then late seizures happen 1 week or longer. And it's really the late ones that you want to watch out for. One late seizure following any degree of TBI is generally considered reasonable for the diagnosis of post-traumatic epilepsy because about 70% of the time having one late seizure is actually then associated with recurrence of additional seizures going forward. So how common is it for people to kind of develop seizures after concussions? And what I always talk about with this is that the devil's in the details with these studies because there's lots of problems that exist with the studies. Just as an example, this is actually what looks like a fairly well done study from Sweden that followed about 1,800 patients and looked at who are developing unprovoked seizures after diagnosis with concussion. But the details of this is that they followed people. So they have this national database of this population registry in Stockholm that follows people following hospitalization. And so what they used is that people that were hospitalized with concussion and then followed over time to look to see, how likely is it that they develop unprovoked seizures at some point later on in their life. And if you're using a hospitalized concussion, so a Glasgow Coma scale of 13 to 15, and they were hospitalized, you have a risk of about 8 times, the relative risk of controls. So a pretty meaningful risk. But you got to think about who are the people that are hospitalized with concussions. We don't, there's about a third to a half of people that don't ever go to the hospital for any reason after concussion, let alone are actually hospitalized. So those people had a pretty significant event, even though their GCS was 13 to 15. That doesn't rule out people that still have bleeds and skull fractures and a whole host of other things that probably led to a hospitalization. And in fact, well-controlled studies that actually remove that. And so this is a Rochester epidemiological study that actually followed 4,000 patients from the 80s or from 1930 to 1995 to look to see who developed things like unprovoked seizures. The groups were broken into mild, moderate, and severe TBI, and the mild group removed anyone that had any form of skull fracture, bleed, or other kind of structural injury. So if you remove any of that kind of stuff, what you see down here in this last bar is that those people have about the same degree of risk of developing seizure as the controls. There's really no difference, almost no difference in the degree of in the likelihood of developing seizures after that. So our guy went through an AMU stay to see what's going on, and what they found was multifocal and generalized spikes. And they diagnosed him with the generalized epilepsy. Generalized epilepsy is genetic; it has nothing to do with trauma. And so they put him on zonisamide, and the neurologist said, "I've got no concerns about this athlete returning back to play," which was, super news for the athlete. The athlete now felt much better about things, responded really well to a combination of vestibular treatments, psychotherapy through the psychologist, and progressive exercise. And then he returned back to testing with us, and he looked good on testing. So no problems on testing with me. Everything returned back to normal. Again, he's not doing particularly well on a couple of these skills, but those are ADHD problems. He's back to where he was pre-injury in these things. And like I said, had no symptoms, was feeling good. I really think a large portion of what we saw in that first evaluation was, again, the concern that this athlete had about retiring related to the seizures and feeling worried that he's having some different kinds of problems. Okay, so those are the two cases that I've got. I'm going to stop my share. I don't know if there's any kind of final questions or things that people want to talk about.
Yeah, thank you for that excellent presentation. I must say, Dr. Goldberg sings your praises, and
Okay,
she did not undersell them. That is for sure.
well, that's good.
Thank you so much. I a couple questions on that second case. Super interesting.
Yep.
Uh, the late presentation of seizures you mentioned has to be at least 1 week after. Is there an upper limit of normal? On the Stockholm registry, it looked like they were following him for over 10 years.
Well, so that was a long time. And again, I think that the thing to keep in mind is I think it's very likely that those hospitalized patients probably did have things like skull fracture and bleeds and other things. That's why they were hospitalized, right? And
Yeah,
so like,
yeah,
and that's what that Stockholm group was doing is they then followed them after that. And even though they were 13 to 15 in the mild range, it's
yeah.
still probably more than that. And so if you do have skull fracture, bleed, these more structural events, then you have increased risk for developing seizure 20 years beyond. I mean, so you have an
Wow.
increased risk for a very long time
Wow.
after an event like that. So again,
Yeah.
structural injury, which it doesn't happen all that frequently in sport, but it certainly does happen. And when it does, then this is why people are on those prophylaxis initially, and then you follow them over time, and they're weaned off often by neurology. But they are at increased risk for other kinds of neurological complications for a long time after an
Yeah,
event.
definitely. And so follow-up question to that is how did they differentiate between generalized epilepsy and the PTE? Was it based off how the EEG looked?
Yeah, so they did an
That's
AIM.
basically it.
So they did an AMU stay, and they followed him while he was an adult medical, inpatient EEG essentially, and then looked to see what the seizures looked like, and they saw that it was generalized epilepsy.
I see.
Generalized epilepsy is almost always genetic. It has again, it's something where so they put him on meds and they made sure that he wasn't having seizures from the meds, and then they were fine with him returning to sport.
Perfect.
Yeah.
Perfect.
So I see
Both,
there's a question too in the
yeah.
chat. You might want to ask.
Both great examples of how reassuring and the education emphasis that you talked about
Yeah.
really can help with the recovery from the concussion. And that kind of dovetails nicely with Vince's question, which is how do you bring this up when you're sensing, hey, this is an athlete who may have some fear avoidance, kinesiophobia.
Yeah.
Um, do you call it out directly? Um, do you
Yeah. So
suggest
I like
psych?
thinking about like peak and pass, where a lot of times it's that they're worried they're going to do something to really derail their recovery, right?
Yeah.
If I get active or if I do these things, then I'm gonna have a whole lot of symptoms, and then I'm not going to be able to go back to sport. A lot of the times it's that kind of piece of things that is going on, and I like to tell people, again, that's not what we see happen. Again, really what the newest Amsterdam statement says is that it's okay to in those initial phases on the exercise protocol to have a little bit of symptoms as you're moving through that. So you can have a little bit of worsening as long as it's not severe and as long as it's not prolonged. And they define that as an hour or more after you have the exacerbation. So if I have a little bit of symptom worsening that resolves within an hour, that's okay. And even if I get the other kinds of problems, just reduce your activity. So again, I think that the idea of kind of normalizing the experience of symptoms and to say that even if you do something and it makes your symptoms a little worse, it shouldn't derail your recovery process.
Yeah.
I think and that is the thing that kind of helps people out. Sometimes people are just super nervous about stuff. They just get anxious about the symptoms and they're worried that they're going to do something. They're worried about returning to sport and then having another one happen. And like I said, if that's the case, then I start talking about, it's not uncommon for people to have an injury and it affects confidence and affects your kind of your sense of your ability to go back to sport like that. And that's when I like to lean on my sports psychology colleagues then to get them in because again that's a common thing that they're used to managing. And I think that most athletes they're a little more likely to feel okay with sports psychology than they are just general clinical psychology. That's been my experience too.
Yeah. That's great. I mean, the your comments and the way you talk about kind of educating, normalizing, and encouraging the movement sounds a lot like how we manage, degenerative changes, osteoarthritis, and that type of thing, in some of our older patient populations, where it's like they're in pain and so they don't want to move, but it's like no,
Yeah,
actually,
you
low
can do it.
intensity steady state is going to be helpful for decreasing your symptoms. So
And I think that the way we have evolved in concussion is very similar to things like our orthopedic injuries. So again, we used to kind of following things like knee replacement and stuff like that. I mean, they kept people pretty inactive, immobile for a little while, and realized that's not very good for you. We need to get you active.
yeah,
And we've
yeah,
done the same thing in the concussion world. We're going to shut you down and cocoon you. It actually makes you worse. We're
yeah.
not going to do that. We're going to try to get you active earlier. We're doing the same process in the concussion world.
Yeah. I just saw a patient today who was shut down and like laying in her bed in a dark room for 4 months and now she's having a whole host of problems.
Exactly. It's
Um,
horrible. It's a very bad thing to do, and it's unfortunate. I mean, again, I feel like we do all this education, but there's still a good number, especially like primary care docs or pediatricians that don't have. I mean, they don't get some of the education stuff, and they're doing many things, right? So so they know just enough about certain things, and so they're doing just some outdated sort of practice at this point, and it just ends up being something that results in people taking a long time to recover.
100%. Okay, two quick questions. We're already over time, but this is such a good conversation.
Sure.
How do I loved how you elegantly navigated the difference between Berlin and Amsterdam statements in relationship to the relevant factors in recovery of sport-related concussion. And when we're seeing conflicting information in the research, that oftentimes suggests we're not thinking about something, which is where you brought up the somatization.
You're
Well,
right.
and so my question is, how do we tell who are athletes with psychological distress? Out of those athletes, how do we tell who are somaticizers?
Yeah. Usually my experience, again, so there are if you want to, there are scales. You can go through and do the separate sort of standalone scales. I'm a psychologist. That's the stuff I do. I think most of the time, that's probably not what our other kinds of specialties are going to do. I would say that just using magnitude of endorsement on the symptom scale is a very relevant indicator. So again, if you're getting really severe endorsement on symptom scales, something else is going on usually. It's not normally now. Again, you see, especially in the very acute phase, sometimes you'll get people that are in the 30s or 40s or something like that. Anytime you see people 50s, 80s, hundreds, like in on those symptom scale, when you're moving way high up there, a lot of the times there's something else. And those are people where I want to get them early into PT. I want to maybe send them on to neuropsych and say, what do you guys think about this? Or just even encouraging them, are you in therapy now? Are you in counseling? It's really common when people have an injury to try to reestablish with a therapist and kind of work on the relaxation and coping side of things because that can be really helpful. So, I mean, I think bringing that in early when we know symptoms are really high is
Yeah.
something that in and of itself is just it's a quick and dirty way of doing it.
Nice. I like that. I like the Gestalt kind of or the generalized approach. Another way to frame that is when symptoms are out of proportion, like pain out of proportion, can suggest certain things. So that's great. And then last question, you gave two examples of how you had two athletes who were worried about retirement, it impacted their concussion experience and recovery. Um, can you quickly run us through maybe a framework? And I know this is a loaded question, especially for 9:30, over past 9:30 at night, for our Eastern audience and
Yeah,
including our speaker. What if the athlete was ready to retire, or you saw
yeah.
something and you're like, hey, maybe it was post-traumatic epilepsy, and you're saying, hey, you really should not be in a contact sport with high prevalence of head trauma.
Yeah.
Uh,
It's these are hard conversations, right? And one of the things that I actually would say that even with the athlete that I did say was we don't think this was seizure disorder or we don't think this was a post-traumatic epilepsy. We don't think that we're concerned about your recovery. I don't like that all of his eggs are in that basket, right? Like
Yeah.
I'm a hockey player. I am nothing else. That's
Yeah.
never a good place to be. And I talked about that with him that, you can blow out your knee at any time. I mean, there are things that can happen that will end your career in this sport. And you're not always going to be this. What are you going to do otherwise? Let's have a plan. Um, and so, again, I think that is an important thing. A lot of times athletes already have that plan. And I would say that even in the cases that I've talked about here too, most of them did. Like the other athlete had an idea of what I would do after. It's
Mhm.
still a big deal to move from this thing that has been like the center of my identity. Like an NFL
Yeah.
player has been the best player on every team they've ever been on.
Yeah.
I've always had this spotlight, and now I'm not going to have that. And when you're out of the league, you're out of the league. When people are out, they're out.
Yeah.
And so it
Hey,
is
Jason Kelsey talked about that.
it's a big deal. And so,
Yeah.
I would just say that it's important for them to have a plan and have a sense of things. But I would also say that, again, there are definitely times that people will have significant injuries. They don't recover well. So in the times we're really thinking about retirement, they don't recover well in the cognitive testing. They are having really light impacts that are blossoming into a lot of symptoms, or they're having increasing duration of symptoms with each successive event. When we're seeing those kinds of things happen, or then also, again, a significant structural injury that neurosurgery or somebody else is worried it's going to bleed again. So those sorts of things when we see these kinds of things, then these are things that, this is just not for you anymore. We need to find something else.
Yeah, that's great. Man, I appreciate you, Dr. Bailey. This has been probably the one of the best talks that I've moderated in a long time.
Well, that's
So
great. I
thank
appreciate
you.
it.
Thank you. I think that's a great way to end it. So appreciate everyone tuning in tonight. Don't forget about next week, hip and knee trauma. But wow, this was excellent. So thank you again.
Absolutely.